Anterior cervical discectomy infusion, or ACDF, is a surgical technique that is often recommended to treat degenerative conditions of the spine, which includes degenerative disc disease, where the disc material slowly degenerates over time and gradually collapses. That can lead to neck pain. It can also lead to bulging of the disc material into the spinal canal, which can cause compression of the spinal cord or the nerves, resulting in radiating arm pain, burning, tingling, and sometimes muscle weakness. Other conditions that this surgery is used to treat would be arthritis of the spine, which also leads to spinal stenosis or nerve compression, and finally herniated discs or ruptured discs, which is where the disc material will develop a tear, allowing some of the inner disc material to protrude out and cause nerve or spinal cord compression. The anterior cervical discectomy infusion, or ACDF surgery, is done through an incision in the front of the neck. That is why it's called an anterior procedure. And the surgeon will use that small incision to access the front of the neck, which is where the discs are. And through that incision, the entire disc will be removed. That allows the surgeon to remove bone spurs and disc material that are causing nerve and spinal cord compression. It also creates a space between the bones, which allows for placement of a fusion device or fusion cage into the space where that disc used to be. In my case, I typically will use a titanium fusion device or fusion cage. The device is hollow in the middle. I fill that with bone graft material, which is basically cadaver bone that has been put through a special process that has been sterilized. And the device will then be placed into position between the bones where that disc material used to be. Placing this device allows the surgeon to restore height back to the space between the bones where that disc has collapsed. If the bones have become unstable or out of alignment, placing the device will also allow for restoration of stability and realignment of the bones back into their proper alignment. In many cases, the surgeon will choose to place a thin titanium plate onto the front of the spine with screws that stabilize the plate to the bones to add extra stability so that the bones can then fuse together over the next several months. The risks of an ACDF procedure really can be broken into three categories. Number one, risks of anesthesia. Number two, risk of things that can happen during the operation. And then finally, risk of things that can happen after the surgery. Risks of anesthesia are low but not zero. Things can happen, including allergic reaction to medication, the possibility of seizures, heart attack, stroke, even death. The likelihood of those things to occur is very low, but every individual would need to find out their own individual risk based on their medical history and conversations with your physician or multiple physicians, including possibly your cardiologist or primary care physician. During the operation, there are structures that are at risk during the surgical exposure. That includes potential risk of injury to the breathing and swallowing tube. There's risk of injury to blood vessels and nerves that travel through the neck. The likelihood of any injury to those structures is less than 1%, but those things may occur. After the surgery, there's risk of infection, approximately 1% risk of infection after surgery. There's also risk of difficulty swallowing. In many cases, patients will have some very temporary discomfort with swallowing. In very rare cases, that can be long-term. Other risks after the surgery would be risk of the fusion not healing completely. Fortunately, there's only about a 2 to 3% incidence of that happening. Many patients want to know if they have a fusion of their neck. Number one, will they lose mobility? In my experience, if I fuse 1 or 2 discs in the neck, most patients cannot tell any difference in their overall motion. The majority of the movement of your neck comes from the upper levels in your spine, which are typically not levels that are commonly fused. So after a spinal fusion surgery or ACDF surgery in the neck, most patients are able to nod their head very easily. They're able to turn their head side to side. So they really won't experience any significant loss of motion. Now, once I fuse 3 or 4 discs, which is not as common, then patients will start to notice more stiffness of their neck after the surgery. They can still turn their head side to side. They can still look up and down, but they may have more overall stiffness of their neck with certain movements. Another question that I often am asked about spinal fusion surgery is if a disc is fused in the neck, will that lead to degeneration of discs at other levels? The answer to that question is yes. If you fuse a level in your spine, it will transfer some motion and stress to the adjacent levels. And over time, those levels may start to degenerate at a little bit of a faster rate than they normally would have. Studies have shown that the incidence of that happening for clinically significant degeneration of an adjacent disc, it's about 2 to 3% per year. So what does that mean? That means 10 years after having a disc fused in your neck, there's about a 20 to 30% chance that one of the other levels may cause significant symptoms and potentially require additional surgery. One of the questions that is commonly asked of spine surgeons and spine physicians is, what is a spinal fusion and why is the doctor recommending this for me? A spinal fusion is a surgery where basically two vertebrae or two bones of the spinal column are joined together, typically with instrumentation or implants, which are typically titanium, and bone graft is placed between the bones, and the bones heal together and the bones unite together and become one. It's almost like welding two pieces of metal together. The reason the surgeon would likely recommend a spinal fusion, there are really multiple reasons why a surgeon may recommend that. Typically, a fusion is done to restore alignment and stability to a spinal segment that has become very degenerated and unstable and is causing nerve compression. In some cases, we're able to relieve nerve compression just by going in and removing bone spurs or going in and removing some disc material. That would be a surgical technique like a laminectomy or something like a microdiscectomy where we remove herniated disc material. In some cases, that's just not sufficient. Many patients develop degeneration to the point where the disc has collapsed severely, and the only way you can relieve the pressure on the nerves is to open the space back up between the bones. Sometimes patients develop instability where one bone slips out of place and becomes out of alignment. And in those cases, the only way to relieve the patient's pain is to restore the alignment back to the bones and to restore the stability. So those are the reasons why a surgeon would likely recommend a spinal fusion. In many cases, a spinal fusion surgery will involve placing devices between the bones of the vertebral column into the space where the disc used to be. The surgeon will remove the degenerated and collapsed disc material from between the bones and place a device in that space. Typically, that device is made from either a special plastic material called PEEK or now in many cases titanium. This device is called an interbody device, and the reason we call it an interbody device is that the bones are called the vertebral bodies, and when we put that device between the bones, we call that an interbody device. The job of that device is to maintain the height and alignment and stability back to that segment between the two bones. In many cases, additional stability will be added by placing screws and rods, or in some cases, plates and screws into the bones to give extra fixation to hold those bones in place. As the bones heal together, the stability increases, and eventually the bone fusion, or the almost like the welding of two pieces of metal together, the bone fusion actually becomes stronger and more resilient to stress than the actual titanium screws and rods or screws and plate. Typically, it takes anywhere from 3 to 6 months for a spinal fusion to heal completely. Once the fusion is completely healed, in most cases, your surgeon will allow you to return to full activity, including sports activities such as golf and tennis. Many patients ask me, after a spinal fusion, is it likely that I will need additional surgery down the road? It is true that once you stabilize a segment and fuse a disc, it will transfer motion and stress from that disc to the levels above and below, making it more likely that those adjacent discs will eventually degenerate and cause symptoms. Now, that may happen anyway, even without the spinal fusion, but transferring the stress to those adjacent discs will slightly increase the rate of degeneration of those levels. Studies have shown that the rate of clinically significant adjacent segment degeneration occurs at about 2 to 3% per year. So what does that mean? That means if you have a spinal fusion, there is about a 2 to 3% per year rate of you having symptoms at the next level. So 10 years after a spinal fusion, there's a 20 to 30% chance that you may have problems at the next disc, possibly requiring additional surgery. An ACDF procedure typically takes about an hour to do a one-level procedure or one disc fusion. In many cases, this is done as an outpatient. Patients really do not need to spend the night in the hospital after the surgery in most cases. Patients are able to walk and climb stairs immediately upon leaving the surgery center. Patients typically will go back to driving themselves, back to office work, sitting at a desk, usually at about 2 weeks after the surgery. In most cases, the fusion has healed by about 3 months. And a fusion is where the bones are growing together and forming a good solid union, almost like welding two pieces of metal together. Once the fusion is completely solid, then patients are able to start physical therapy for neck strengthening, range of motion, and gradually return to full activities, including golf, tennis, back to the gym, exercise, running, skiing. Basically, any athletic or recreational activity that they want to return to, they're able to do that. As an example, Peyton Manning, very famous NFL quarterback, was able to return to the NFL and win a Super Bowl after having a disc fused in his neck. So that just goes to show that you can return to a very high level of athletic activity following a cervical fusion or ACDF procedure.